I think for blast phase MPN, I think what we know is that intensive chemotherapy is not the same for blast phase MPN as it is for de novo AML. And really, these patients with blast phase MPN, their disease has long been going on, and a lot of times they have damaged bone marrow, fibrosis, osteosclerosis, really inhospitable bone marrow environment, and then to give intensive chemo on top of that renders, one, toxic, and two, very difficult to recover counts. And oftentimes they have a clone in their disease that's also somewhat resistant. So sometimes it's not even that effective. And I think when we've looked at historical outcomes with intensive chemotherapy, they've been terrible. Increasingly, we're using hypomethylating agents, which it's unclear if those are doing a lot more in terms of response, but I think they're actively not hurting as many patients as intensive chemotherapy does. We got excited when venetoclax started being used in combination with HMAs, but unfortunately, it doesn't look like that benefit we see in de novo AMLs and elderly AMLs is really extended to the MPN population. It may help with response rates, but survival doesn't appear to be meaningfully impacted. So I think this is probably the biggest area of unmet need right now within MPNs, is to develop novel, intelligent, targeted strategies to really improve the outcomes for these patients with accelerated or blast phase disease. Ultimately, we want to get them all to transplant, right? But that goes without saying. I think that just means that we have no good options for them. We need to be able to figure out ways to actually get their disease to go away so they'll be better transplant candidates when we get them there.